Hello, welcome to the ACA 2021. My name is William Sawyer. We're going to start off the program by discussing corneal considerations for cataract surgery. I have nothing to disclose financially. The objectives today will be to learn options of treating corneal conditions before, after, or during cataract surgery, discern when astigmatic correction is appropriate with intraocular lenses, and learn what discussions help prepare patients for corneal problems after cataract surgery. These are my references. As I mentioned a minute ago, my name is William Sawyer. This is Corneal Considerations for Cataract Surgery. This is a picture of mine from a few years ago, but I like the way I look in it better than my current pictures, so I'm using it. Let's jump right into Fuchs corneal dystrophy in the setting of cataract surgery. So I've been out of my residency for 10 years now. When I was in there, we were taught corneas that had a thickness of 640 microns with Fuchs corneal dystrophy had a high rate of decompensating with cataract surgery. But this was really in the days when the treatment for Fuchs corneal dystrophy was a penetrating keratoplasty. Nowadays, we use endothelial keratoplasties the far majority of time in Fuchs, and this has really changed this thinking dramatically. In my mind, this old rule no longer applies, and I don't know really any corneal surgeons who live or die by it at all, or really even bring it up anymore. The old triple procedure was a PK, cataract surgery, and intraocular lens placement. The new triple procedure is a DMAC, cataract surgery, and intraocular lens placement. And this is a little video just walking you through it in case you've never seen a DMAC before and kind of explaining the steps. Hopefully you've got to see a DMAC or at least see patients who've had it in the past, because it is very, very impressive when you compare it to PK especially, but even to DSEC as well. So to start, you do your regular cataract surgery, much like you always would. Phaco, IA, and intraocular lens placement. After this, I'm creating a peripheral iridotomy inferiorly to help with the gas bubble management after the surgery. I'm marking the cornea at 8 millimeters, and now I'm scoring the corneal endothelium and descimase, and then we're going to just strip out descimase membrane and the endothelium, leaving all of the rest of the stroma behind, all the structure. Removing the viscoelastic, putting in a little myocol or myostat to bring the pupil down. And now I'm putting in the DMEC, the endothelial keratoplasty. And I'm injecting this through a 2.4 millimeter incision. And once it goes inside the eye, we do not want to touch it anymore, because any touching will lead to more endothelial loss. And obviously we want as much endothelium as possible. I still put a suture in the wound, although I know many surgeons who don't. I've just had things try to come back out at me. And now we're dancing with the cornea. This is where we press on the outside of the cornea in different ways, little flicks, little presses, to send fluid waves inside the cornea to unroll the graft. The graft is endothelial side out, so if you touch it, you're going to touch the endothelium. So now I've unrolled it, I'm trying to center it. Now I'm cussing in my head for going a little too far and scrolling it back up. Get it unwound again, and I'm going to do a little press suction to move it into the center of the cornea. Once it's centered nicely, and we know that the endothelial side is down, that's what the S stamp is for. We're going to put an air bubble in to press the graft onto the posterior cornea. Now I'm equalizing the pressure in the eye and managing the size of the gas bubble, and we're done. That's the new triple procedure with a DMEC. These DMECs now come stained and stamped so that you know when you've got the endothelium up or down. They come preloaded in the injection tubes. The eye banks are quite adept at these tissues nowadays, which makes cornea surgeons' lives much, much easier. Now, when you compare this to especially a PK triple procedure, I mean, you can see that it's just nowhere in the same ballpark as far as how safe it is and how atraumatic it is, comparatively speaking. Um, so, why should we use the same rules that we used to use for a PK with Fuchs and cataract surgery when we've got such a better procedure? We've got to make up new rules and think of our patient's best interest on when we should go forward with these surgeries. The results with DMEC have been quite impressive. In eyes that have no other real pathology, um, DMEC is the post-op vision in DMEC is ranging between 2021 and 2031, so basically 2020 and 2030. The rejection rate is very low, 1 to 2%. And ultra thin DSEC is showing similar results. Ultra thin DSEC is where you use a graft that has about 50 microns of stroma, and it's a little easier to use in eyes that are more complex, such as eyes that have had glaucoma surgeries or one chamber eyes that are aphakic or have a scleral fixated intraocular lens and don't hold a bubble quite as well as a two-chamber eye. So let's jump right into the difficult situation as to whether we do just cataract surgery or we do a combined endothelial keratoplasty and cataract surgery. We have a 65-year-old, 4 plus gutata, no discernible edema yet, but they have a visually significant cataract. Do you do a straightforward cataract surgery or a combined surgery? Remember, this patient's only 65, so they will likely go on to need an endothelial keratoplasty at some point in their life. In an ideal situation, this is what I would recommend. If you think the cornea looks worse than the cataract, the cornea is causing the bigger visual problem, then I would do a combined cataract EK, or if you don't do this, then send them to a cornea specialist for a combined cataract EK. If the cataract looks worse than the cornea, then I would do the cataract only, but I would have a very long discussion with them about how they will likely need a cornea transplant soon after the surgery if their cornea doesn't survive, or later, especially in like our current patient who's 65 and already has 4 plus gutata. There's a high chance at some point they will develop corneal edema and need an endothelial keratoplasty. Unfortunately, what I find happens in real life is nothing like this and usually does not depend on which one the doctor feels like is the bigger visual issue. I find that if the patient is familiar with their Fuchs diagnosis and has been told about it for a long time, they usually prefer to do a combined cataract and endothelial keratoplasty. I find that when ophthalmologists send me a Fuchs patient, this is usually the case. These patients like the idea of just having one surgery per eye and not having to stage this out over a long period of time. But if the patient is not familiar with their Fuchs diagnosis, they usually have a hard time wrapping their mind around the fact that they will need a cornea transplant and would prefer to give their eye a try with just the cataract, and then if it just fails, then go forward with the endothelial keratoplasty. Unfortunately, I've seen this multiple times on new patients, or sometimes I've noticed a number of optometrists in my area will send in patients for cataract surgery and never mention anything about Fuchs. And a patient will come in with quite advanced Fuchs, and we have to have this long talk. This tends, like I said, to scare the patient to where they would just prefer to get the cataract out and see what happens. When we do that, I usually tell them, I usually have a long counseling session with them and tell them I'm just going to plan one cataract at a time. We'll do one, let it heal for 3 months if we need to, and then either do the other eye if the first one did well, or do a transplant on that first eye. If the first eye needed a transplant that fast, then we'll just do a combined with the second eye. Here are some tips you can use when discussing endothelial keratoplasties with patients that you think will eventually need them. First, explain the disease to the patient long before you think they'll ever need a transplant. This just helps them come to terms with it, and it helps them know what to expect. Also, discuss with them that the endothelial keratoplasty involves them laying on their back for 1 to 2 days after the surgery. The gas bubble in the eye pushes the transplant up against the posterior cornea, well, gas is going to go up. So the eyeball has to look up for 1 to 2 days afterwards in order to let the cornea adhere to allow the graft to adhere to the patient's cornea. This means they can get up and use the bathroom, they can get up and eat, but otherwise they need to be laying on their back looking at the ceiling. They cannot watch TV because that is not straight up above them and their eyes won't be pointed up. I prefer in Fuchs patients to have the cataract removed at an earlier stage to reduce the chance of them developing corneal edema right afterwards. There's really two trains of thought on this. You can either remove the cataract early, or you can wait until they absolutely need the cataract removed, but you'll likely use more phaco energy in that last case, and you have a higher chance of immediately having to deal with lots of corneal edema. The other reason I like the cataract removed at an earlier stage, the DMAC surgery is actually more successful when you do it alone rather than combined. There's less chance of the graft dislocating and needing to be rebubbled when it is done alone than when it is combined. So if you can have the cataract out a year or two before ever needing a transplant, it usually goes smoother. When deciding what to target your intraocular lens or your target refraction after cataract surgery in an eye that you think will need an endothelial keratoplasty, here are some good rules of thumb. First of all, if the person has mild Fuchs and you think they will never need an endothelial keratoplasty, just shoot for plano. If you do DMEX or the cornea surgeon you send them to does DMEX, then you want to aim for about a -75 because a DMEC on average will push a cornea between a +50 and a +75 hyper afterwards. If you do a DSEC, or if the eye is more complex and you think we'll need a DSEC, you need to aim a little more myopic with your intraocular lens, a -75 to a -1. DSECs just tend to push they tend to give a more hyperopic refractive shift than DMEC. Now let's move on to keratoconus and cataract surgery. So with keratoconus, you really want the cornea stabilized. You want it to quit progressing before you do cataract surgery to get your best visual outcome. It's not always possible, but ideally this is the thing to do. This can be done in many different ways. First of all, cross-linking. You can have the cornea cross-linked in order to stop any keratoconus progression. If the cornea is stabilized, and Intacs will be used to flatten it. This should be done before cataract surgery. I prefer, if a cornea is going to need a penetrating keratoplasty or a deep anterior lamellar keratoplasty, to have this done and stabilized long before the cataract surgery, and we'll talk a little more about this in just a minute. The other way of stabilizing the cornea is with age. Thankfully, natural sunlight creates cross-linking in our corneas. That's why most people with keratoconus usually stop progression by the time they're age 50. And as we know, most people who need cataracts are older than that. So most of the time, if a person hasn't had severe keratoconus, it's already going to be stabilized by the time they reach cataract age. Now, if a patient's cornea is bad enough to need a penetrating keratoplasty, I like to do this staged. I like to do the penetrating keratoplasty first and then wait till I'm done removing sutures and have stabilized that cornea before coming back for the intraocular lens for the cataract surgery. Now, this is a running suture. I use this picture because it looks pretty in a lecture, but most of the time I actually do 16 simple interrupted sutures. I let the cornea heal for 3 months, and then I start taking out sutures either one at a time or two at a time until I've either removed them all or found a cornea shape that I like. The reason I like to do this before cataract surgery is you'll get a much better visual outcome. You can calculate the new intraocular lens based on your new cornea and not end up with some kind of wild refraction. If you want to use a toric lens, you can. We'll talk a little bit more about that in just a few minutes. The other reason, I find the triple procedure where you do a cornea transplant and do cataract surgery under open sky to be possibly the riskiest procedure in all of ophthalmology, with definitely the highest risk of an intraoperative expulsion. And by doing the transplant first and then coming back for the cataract, you minimize that chance. You also will end up with much more wild refractions with a triple procedure than you will with a staged procedure. Now, the bad part about a staged procedure is you will harm your cornea somewhat by going back in and getting rid of that cataract. You can, however, do an endothelial keratoplasty under a PK if you needed to. So if they have keratoconus but no PK is needed, then a lot of this has to do if a patient will wear a scleral contact or not. If they have a large amount of astigmatism, and this is going to play into a lot of the things we're going to talk about from here on out, but with keratoconus, they usually do have a large amount of astigmatism, and they will wear a scleral contact. Then I'll put a regular intraocular lens in their eye. If the patient will never wear a scleral contact, then I will put a toric lens in their eye if they would like that. In anyone with an irregular cornea, I want to make sure that my refractive axis is stable, and then to make sure the toric alignment is at least close to that axis, or at least makes sense with it. I find the most wild refractions are when the toric does not align with their pre-op refraction. I never ever promise glasses freedom in these patients. It's very rare to get them completely to plano sphere or close to that. Most of the time you're taking someone from a large amount of astigmatism, 4, 5, 6, 7, 8 diopters of astigmatism, and reducing it with a toric lens to 1, 2, or 3 diopters, which obviously creates a much greater quality of vision, better quality glasses afterwards, but is definitely not enough for them to see everything without glasses. So you always want to emphasize this will not get you out of glasses if we use a toric IOL, but it will get your glasses prescription to a much more reasonable level. Another thing I always do in keratoconus cataract surgeries is put a suture in the incision. My cornea attending, Dr. Mauger, always told me, do not trust a keratoconic cornea. These wounds, more than any, are likely to leak, or if a person just barely rubs them, they can bust them open much, much easier. They're very floppy, unstable corneas. And I find putting a suture in and taking it out at a week or a month is just an easy thing to do. I might as well save myself the headache in the long run by doing the work up front. Now let's move on to corneal scars in cataract surgery. So corneal scars obviously are all over the map. You can have really, really bad scars, you can have scars that are just not significant at all, and everything in between. As we know, trauma situations, you take what you get. So these are some easy scenarios. If a scar is really bad and you can't even see the cataract, or you can't see it well enough to be able to perform cataract surgery safely, then they're going to need a penetrating keratoplasty or a DALK first, um, or a triple procedure to be able to deal with the cataract. If the scar is light enough not to affect the vision or astigmatism, then you don't even really have to worry about it and just do your cataract surgery as usual. And this is by far the majority of scars. We see foreign body scars all the time. But we really want to talk about the in-between scars, scars that are just all over the map on how they're affecting the vision. Scars, they're just like any other trauma. You take what you get. So, if the scar is affecting the astigmatism, but it's not in the visual axis, then I'll either do a regular intraocular lens if the patient will wear a contact afterwards, a scleral contact or an RGP. But the far majority of my patients will not wear a scleral contact. Most of my patients are older and they have no desire to even try, or even if they do, they're not agile enough to put a scleral contact in. And so in their case, I do believe it's reasonable to put a toric intraocular lens in if you feel like the astigmatism is regular enough to where you'll be able to reduce it with the toric intraocular lens. Obviously, this is just if the patient is never going to wear a contact. Here's the reason for that. If you put a regular lens in and put a scleral contact on, the scleral contact is going to get rid of the irregularities in the cornea. The BSS or artificial tears are going to fill in all of the little valleys in the cornea, all the irregularities, and provide a smooth cornea. And this is true with corneal scars, keratoconus, or other irregular corneas. So in essence, they will no longer have any astigmatism. However, if you put a scleral lens in front of a toric intraocular lens, all of a sudden you've uncovered their internal astigmatism with that intraocular lens. And now the person is going to need glasses on top of their scleral contact, or some very expensive and specialized scleral contact that can also contain astigmatic correction. Now, for scars that are in the visual axis, obviously if they're just super dense and you couldn't do the cataract surgery with that much corneal clouding, or you felt like it was going to be very poor vision with cataract surgery, then you just do a transplant first. But when the corneal scar does not justify a PK, these are some things to consider. Most of the time, you would just do a regular intraocular lens or a toric lens as before. And a lot of these patients take a lot of counseling. This is the time where our job as a doctor is to sometimes tell people, yes, you do have a problem, but it's not bad enough to where we need to fix it. If a person has a scar, the only way would be to get rid of it would be to do a penetrating keratoplasty, but their vision's not that bad, then you just have to say no. The treatment is worse than the disease, and unfortunately, you will have to live with this visual problem. I usually say it nicer than that, but that's the truth. Now, one thing you can do if the scar is in the very anterior cornea is aggressive PTK or PRK followed by cataract surgery once the cornea is stable. Well, a rule of thumb to remember is that for every 12 to 16 microns of tissue that you remove, you're going to make them 1 diopter hyperopic. So this is a patient of mine. She is a 70-year-old Caucasian female who couldn't really get a good refraction on her, so she was somewhere around Plano, and her vision was 2100 due to both a corneal scar, an anterior corneal scar, and a cataract. I removed 120 microns of corneal tissue with PTK and greatly reduced the scar. But I made her a +10 hyperope by removing that much tissue. My plan was to wait 3 months and then do the cataract surgery. However, her case kept changing drastically. Something also to remember, the older the patient is, the slower they will heal. She took a whole year to stabilize to where I was comfortable going back in, or comfortable with my intraocular lens calculations. And finally, I went back in and did cataract surgery, and she ended up a -150, +75, and 164 with a vision of 20/30. I didn't get the entire scar, but I got most of it, and she was just very, very happy. But also remember, if you're going to consider this, this is not a great idea if HSV is the reason for the scar, because your PTK or PRK can actually activate the virus again, and you might end up worse off than where you started. Moving on to irregular astigmatism, RK, and post-laser vision correction corneas. So some eyes have very different Ks between topography and keratometry, or between refraction and topography. Some RK eyes especially, and some post-LASIK or other laser vision correction corneas have very irregular topography or very central differences in their cornea. You may sometimes get very different, especially with RK, very different Ks between the 1 millimeter zone and the 3 millimeter zone, or the 3 millimeter zone and the 5 millimeter zone. How do you deal with that when you're trying to calculate what to do with an intraocular lens? So one thing I like to do is make sure that I use the Ks that are closest to their photopic pupil size. The machine I use will give me their wavefront refraction and topographies at different areas of their cornea in photopic and in scotopic conditions. Well, as humans, we're not nocturnal, so most of the time we're going to use our daylight vision. So I like to use the Ks that are closest to our daylight vision. This may mean, though, that they have a different refraction at night and may need a different pair of glasses at night. Something good to warn them about. A different thing that you can do is just average all of your different Ks together between all the devices and go with those. One rule of thumb I always have with all irregular corneas is to make sure that the Ks make sense with my refraction. If the Ks are just totally different than the refractive axis or the refractive magnitude, I want to have a good reason for that. Whether that's the posterior cornea or something else, I need a decent reason before I'm comfortable with those Ks. So this is a patient that came to my practice. She'd already had cataract surgery in the left eye, but she had some very irregular corneas we'll get into in a minute. This is her refraction in the dark versus the light. She came for cataract surgery in the right eye. And as you can see in the dark, her astigmatism is 4.75 at 19. In the light, it's 225 at 145. Big, 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 big difference between night and day. she had had early generation AKs. Instead of making them out near the limbus where we do nowadays, at first they used to make them at the 5 mm zone. So she had AKs at the 5 mm zone of her corneas. They were centered on the 30-degree axis in the right eye and the 150 axis in the left eye. This is her topography in the right eye. And if you look at that central top slide, that's the central topography. The arcs are centered at 5 mm, and it's given her this odd appearance with this flat bow tie at about 30 degrees, and then two circles that combine at the middle to give her a figure-8 cornea. Just a very odd appearance and a very difficult cornea to toric plan. If you look below, the thing that says REF is her autorefraction during photopic conditions, during daylight conditions, and the WF at 5.65 is her wavefront refraction in night conditions. And you can see the cylinder is greatly different between those two, and actually her cylinder on that wavefront refraction was greatly different than our dark manual refraction we did in clinic, which showed 4.75 diopters of astigmatism. So I went back and looked at all of the different Ks we had gotten for her. At the OPD2 I have in one of my offices, it showed us she had 1.7 diopters of astigmatism at 153 in the right eye. My OPD3, it said only 0.81 at 122. And then the IWIL Master 700 with total cornea, where it can also measure the posterior cornea, said she had 2.82 diopters of astigmatism at 136. So when we went to the operating room, a T6 lens was chosen preoperatively with an axis of 137. Aura was used during this operation, and after looking at Aura and comparing it to the preoperative measurements, the lens was changed to a T5, and the alignment was also changed to an alignment at 128. And actually, when I went back and looked at her figure-8 topography, the 128 was more in line than 145 was with where the steep topography or where the topography looked like it was its steepest. Now, thankfully, things turned out quite well with her. At 1 month, she was 20/25 in the right eye. She never got down to 20/20 and would take us a little back and forth on her refraction, but for the most part, she was plano sphere, and she was quite happy and quite satisfied with her results with that toric lens and alignment. Now here is another case of a 68-year-old male who had hyperopic LASIK. He's having doubling of images in his left eye. His left eye is all over the place with the refractions. -1 sphere, -1, +1 at 145, -3, +2, 25 at 88. Just everywhere with his refraction. Now here is his topography, and as you can see, his central steepening is low, and it's right at the edge of his visual axis. It goes from very steep, 49 to 45, and it all happens right at the visual axis. In fact, when we check him in the dark and the light, he's just all over the map with his refraction. Now, part of my discussion with him was that you will not get rid of all of this doubling. You're going to have some just because of the way your cornea is shaped. But we will try to minimize it because you do have a visually significant cataract and at least hopefully improve the quality of the vision in your eye. I actually tried a superficial keratectomy on him first to see if I could smooth this out. It did not. I allowed about 2 or 3 months and it just stayed the exact same topography. So, decided to go ahead with cataract surgery. Now here is my IOL planning software, and this is what I use one called Veracity, and this is what it was suggesting to do. It was suggesting to put in a T9 lens and make 60-degree arcs centered at 76 degrees. So it's going full out on his astigmatism because it's just crazy high in on the IOL master from which this gets its data. I'm not comfortable with this at all. He is ranging from -1 sphere to 225, not near this much astigmatism, not near uh, 5.78 diopters of astigmatism at 76. So instead of going with this, I also look at this and my axis sometimes is close to this, but sometimes it's very, very far from this. So I decided to play it much safer on him. I placed a non-toric lens, and it's in 68C since he was a hyperopic LASIK patient. 14.5 diopters, as my IOL master was saying to put in. And I decided to make a couple of arcs at 76 because I wasn't really sure if I should trust my planning software or not. And arcuate incisions, I use laser for it, and they're very forgiving. So I thought it would, you know, it's not going to cause too much of a problem if I put those in. Unfortunately, he still ended up with a pretty significant glasses prescription. Now, as you can tell, it's still bad on his astigmatism, but also just plain missed on the spherical correction, and this is the biggest problem. But look at his axis, 135. If I had treated 5, nearly 6 diopters of astigmatism at 76, we would be even further all over the map with his astigmatic correction. So I went with my rule of thumb where the refraction needs to at least make sense with the Ks and for toric planning, and decided not to put a toric lens in because I could not safely figure out one that would work for him. Now, unfortunately, I'm going to have to fix this up, and I'm trying to decide what would be better right now, whether to do an intraocular lens exchange or to try and do PRK on top. And hopefully by the time we do the Q&A for this lecture, I will have figured that out, and I can give you an update on that. So in summary for this lecture, consider combined DMEK and cataract surgery earlier than you did if you grew up in the times of PK or even DSEK and cataract surgery for Fuchs patients. The results after DMEK, if you can remember, are between 2020 and 2030, and the rejection rate is very low, 1 to 2%. So this surgery can be considered earlier in patients with who are on the fence of needing a transplant and cataract surgery. The other thing too is it's nice to get cataracts out earlier in Fuchs patients because we have such good results now with partial transplants, and we don't have to think that we're going to push them into a penetrating keratoplasty. Do not use a toric if a patient will use a scleral contact in irregular corneas. A scleral contact or a comparable specialty contact will give the best quality of vision that a patient can have if they can wear it, if it'll fit, and if they'll actually wear it. However, most patients won't. Most patients will not wear a scleral contact either due to a hard time getting them in and out or due to cost. These lenses definitely have a significant cost to them and have to be replaced every now and then. In that case, do consider a toric lens in order to reduce their astigmatism to a more reasonable amount that you can put in glasses. And then on a toric lens in an irregular cornea, when in doubt, make sure that the toric axis makes sense when you compare it to their refractive axes. It won't always work, like I showed in the last case, but the last case, had I gone with the toric lens, it probably would have been worse than than what I did. And and this will save you a lot of heartache in the long run if you just think, okay, this toric lens makes sense with with how much sill they have pre-op and the axis of that sill pre-op. Thank you very much for your time. And if we have any questions, I believe we will have a live Q&A in just a little while that I will be happy to answer.